Thank you, Chairman. It is my great honor to present here today. My talk is about update in HCC pathology. I have nothing to declare. In WHO, update in HCC is supported by novel molecular pathological findings. 35% of HCC can be further subclassified into distinct subtypes with morphomolecular and clinical features. There are 8 subtypes. MTM and neutrophil-rich HCC shows worse prognosis. Steatohepatic HCC, fibrolamellar, and chromophobe HCC show a similar prognosis to compare the conventional HCC. Lymphocyte-rich HCC and the clear cell HCC shows a better prognosis. Cytokeratin 19 is a poor prognostic marker. In this talk, I will focus HCC with aggressive behavior. Here is HCC, and we apply 2 markers of cytokeratin 19 and hepatocyte markers. Blue cells are expressing cytokeratin 19. You can see intratumoral heterogeneity. The tumor cells expressing cytokeratin 19 is a so-called cancer stem cells, is a malignant neoplastic clones showing stem cell-like properties, including greater ability to form tumor and resistant to chemotherapy, and etc. And the cytokeratin 19 expression HCCs, the instance is 4 to 28%, and the clinical features include frequent association with hepatitis B virus, high serum alpha-fetoprotein levels, and more invasive growth, and lymph node metastasis, and poor prognosis. Here is the Jessica's group's molecular classification. G123 is related to p53 mutation, 456 is beta-catenin mutation, and G4 shows no mutation of p53 and beta-catenin. G123 is more aggressive compared to the other groups. And the progenitor phenotype expressing cytokeratin 19 is belong to G1. In other molecular classification, cytokeratin 19 expression belong to aggressive group of S1 and S2 by Hoshida's classification, and it also belong to proliferation class and cluster A and vascular invasion signatures. In pathological features are poorly differentiated, more infiltrative growth without the tumor capsule, and vascular invasion, and more fibrous trauma. You can see fibrous trauma between tumor cell cores. Actually, cytokeratin 19 expression is a heterogeneous and focal. And how we can expect the cytokeratin 19 expression in a biopsy HCC? We compare the cytokeratin 19 expression in matched biopsy and the resected HCCs, and the accuracy is for 86%. And in resected specimen and the biopsy specimen, cytokeratin is a poor prognostic marker. So cytokeratin 19 expression is a good marker in the biopsy HCC material. And there is a correlation between alpha-smooth selectin positive cancer-associated fibroblast and the cytokeratin 19 expressing tumor cells. Here you can see alpha-fetoprotein expression and the cytokeratin 19 expression. In vitro studies, we found that cytokeratin 19 expression is regulated by HGF released from cancer-associated fibroblast and actin met on the surface of epithelial cells and activated MEC-ERK and binding the cytokeratin 19 promoter, JUN4 and SP1. And actually, in TCGA data analysis also showed that there is a close association between CAF, MET-mediated signaling activities, and cytokeratin 19 expressions. And actually, MET signaling is frequently observed in cytokeratin 19 positive HCC suffered the aggressive behavior of these tumors. So cytokeratin 19 is a poor prognostic marker for after resection or liver transplantations. In other ways, cytokeratin 19 HCC can be used as a marker for limited expansion of liver transplant indications. HCC patient beyond the Milan criteria. However, there is no gene expression of process markers, including cytokeratin 19 and S2, achieved survival rates similar to those within Milan criteria. Here, the cytokeratin 19 and the S2 negative cases show a better overall and recurrence-free survivors. Cytokeratin 19 is also a marker for local regional treatment. TACE is one of the most popular local regional treatment. However, the response is variable. In vitro data, cancer stem cell population is expanded through HIP1 and HIP2 pathways under hypoxia. So we checked biopsy, TAC, and resected HCC, the expression of stemness marker expressions. Here is the each cases. The cases without the expression of cytokeratin, epicam, or hypoxia marker cytokeratin 19, these white box cases have a more chance to have a total necrosis. Here is the cases of all negative of these markers have a high chance of total necrosis induced by TACE. Here is the examples. Total negative for cytokeratin, epicam, and CA9 shows a total necrosis. In transplanted cases, the more sessions of TACE, the cases show more chance of expression of stemness markers and hypoxia markers. Here is a case, no TACE, 1 to 3 sessions and more than 4 sessions. The expression rate of cytokeratin, epicam, and CA9 increased, and they are very well correlated. So in summary, here is the cytokeratin 19 positive HCC and the negative HCC. In TACE, the tumor cells expressing cytokeratin 19 has a more chance to survive and then more chance to regrowth. And the different tumor environment is also involved in this process. And the cytokeratin 19 is also show a resistant to systemic chemotherapy. Cytokeratin 19 positive HCCs have shown resistant to chemotherapeutic agents such as 5-FU, doxorubicin, and sorafenib in vitro studies. Sorafenib resistance was associated with the gene signature of cytokeratin positive HCC and with EMT and the hypoxia microenvironment. However, we need further study about this process. Cytokeratin 19 HCC. How about the immune checkpoint inhibitor therapy? It is also remains to be evaluated. PD-L1 expression of HCC is about 15 to 83%. It is very heterogeneous. High PD-L1 expression in cytokeratin 19 positive HCCs are reported. In our code, with a high infection of HBV, cytokeratin 19 expression, HCC, the PD-L1 expression in tumor cells is about half cases. So we need more study for immune checkpoint inhibitor response in cytokeratin 19 positive HCCs. How about the extrahepatic HCC metastasis pattern? We compared lung, lymph node, bone, brain, adrenal glands, and the histopathology of HCCs. Bone, brain, adrenal glands did not show specific patterns. However, lung and the lymph node shows a very distinct features. In lymph node, there is a high expression of cytokeratin 19 and EMT high features. In contrast, pulmonary metastasis, MTM HCC, VTC HCC are more common, and there is a low EMT features. I will explain MTN and VTC in more detail. Macrotropical Massive Hcc. This subtype shows a predominance of macrotropical growth pattern in more than 50% of tumor area, and the HCC code is composed more than 6 cell thickness. Here is the example. These are tumor, and you can see macrotropical patterns, and these thick tumor codes are more thicker than 6 cell thickness. The instance is 5 to 20% and relate to the HBV infection, high alpha beta protein serum level, frequent vascular invasion, and poor prognosis. The molecular features include p53 mutation, FGF amplifications, and angiogenesis activations. And it belongs to G3 by Jessica's classification. And this is MTM pattern can also be detected in biopsy material, and in biopsy material, findings are also related to poor prognosis. How about the VTC? Thinking about the tumor vascularization in HCC, there are two patterns, capillary pattern and the VTC pattern. VTC pattern vessels encapsulating tumor clusters. In other words, it is a sinusoidal pattern. In CD34 immunostain, you can see endocellular cells encapsulating tumor cell clusters. And in multi-institutional studies, we compared VTC and non-VTC HCCs. VTC HCCs are correlated high alpha-fetoprotein, large tumor size, poor differentiation, macrotropical pattern, MTN, and vascular invasions. Especially VTC is related to vascular permeation. MTM and macrotropical pattern is more enriched in VTC pattern, but MTM and VTC are not the same category. Compare the prognosis, VTC pattern are related to early recurrence, disease-free survival, and poor overall survival. VTC is a novel vascular pattern promote to metastasis of HCC in an EMT-independent manner. The endocellular entrapment of tumor cell clusters forming non-capillary network is prone to open into larger ones and facilitate delivery of metastatic tumor cell clusters. Fang's group recently reported that in androgen receptor low condition, angiotensin II increased vascular remodeling and promote VTC-mediated metastasis. In contrast, angiotensin high group, LAG1 promote lamellopodia formation and invasion mediated metastasis is increased. VTC pattern is also a predictor of chemotherapy response. Sorafenib is effective in prolonging the survival in the VTC positive HCCs, but not VTC negative patient. So in summary, lymph node metastasis, cytokeratin 19 high expression, EMT high, and this lymph node metastasis also shows a high immune cell infiltration and a high PD-L1 expression. In contrast, lung metastasis shows a high MTM, high VTC, and EMT low, and less immune cell infiltration and increased angiogenesis features. And these different features may have some clues for the further immunotherapy or chemotherapy in the future. Actually, hepatocellular carcinoma shows various immune environment. There is an immune high, immune mid, and immune low subtype. Immune high subtypes includes Hoshita's S1, Jessica's S2, and the high expression of interferon-related genes and the PD-L1 and the PD-1 expression. In contrast, immune low subtype includes Hoshita's S3 and the Jessica's G5 and 6 and the beta-catenin mutation groups. Therefore, there is a heterogeneity in the immune and microenvironment of HCC, and by integrating the immune microenvironment state of HCC, we may find biomarkers for HCC immunotherapy in the future. Here is the take-home message. HCC with aggressive behavior include the cytokeratin 19 expression, MTM, and the VTC subtypes, and etc. Metastasis to lung and the lymph node shows different pathological features. Lung metastases have a greater proportion of VTC and the MTM subtypes and less inflammatory cell infiltration. In contrast, lymph node metastases have a higher cytokeratin 19 expression, EMT high features, and fibrous tumor stroma with a high immune cell infiltration. Therefore, further study for the relationship between pathological features of HCC and its underlying molecular alteration may help in developing molecular pathological classification of HCC with pathogenetic and clinical implication. Thank you for your attention.